Welcome to part one of our three-part series where we dive deep with leading experts in the field of medicine. So get ready for insightful conversations. Let's get started. Hello and welcome to the EMJ podcast with me, your host, Dr. Jonathan Sackier. Today, I'm joined by Zoë Paskins, Professor of Rheumatology at the Primary Care Centre versus Arthritis at Keele University here in the United Kingdom, and an honorary consultant rheumatologist in Stoke-on-Trent and a National Institutes of Health Research, or NIHR, clinician scientist. She's the research lead within Keele's Impact Accelerator unit and is passionate about ensuring that research leads to positive change in clinical practice. Zoë obtained her medical degree from the University of Leicester, completed a PhD at the University of Keele, and trained in Leicester and the West Midlands. She's an active member of the National Osteoporosis Guideline Group, chair of the Musculoskeletal Disorders Research Advisory Group, and sits on various committees for the Royal Osteoporosis Society. She's a special interest in applied health research to improve the care of people with osteoporosis. When not practicing rheumatology, Zoë enjoys music, having previously sung in a band, and playing with her puppy, who, when we were due to record this, unfortunately suffered a broken elbow, which is kind of appropriate, really, given that she's in musculoskeletal disease. I hope she could look after the poor little thing. I'm looking forward to this conversation. So, Professor Zoë Paskins, welcome to the podcast.
Thank you for having me.
So, first of all, how is the puppy? What make of dog is?
He's a very bouncy English setter, and he's now about 10 months old, and he's really in the naughty phase. So every time we turn around, he's got something in his mouth he shouldn't have. And this week he's already ruined a pair of flip-flops and an expensive pair of Doc Martens.
Oh
But I
dear.
do love him, I think.
I recommend there's a book I read a while back, and I recommend it to everyone I speak to. It's called Inside of a Dog,
Right.
written by a brilliant lady. She's an ethologist who studied bonobos, got a dog, and took some video, I believe, when it was a little puppy first time in the park, and when she noticed in slow motion the facial expression, she thought, "My goodness, that's just like a bonobo." And she ascertained that there was very little research on dog behaviors. I have to anyone who's got a dog, read this book. It changed my relationship to my dog. So
I've written it
yeah,
down. I'm going to do that.
good on you, good on you. And before we dive into your work, which we are going to do, what kind of music did your band play, and do you still sing in your free time?
Oh God, it was such a long time ago. It's difficult to classify. It's kind of a mix of genres, but maybe a bit of hip hop and dub at the time. We're talking well over 20 years ago. But um, I really like going to see live music now, and I'll sing loud in the crowd, but that's probably about as much as I do now.
Well, good on you. Clearly a multi-talented lady. So can you share with us what initially drew you to rheumatology and what's kept you passionate about it throughout your career?
Yeah, I think when I was training, I liked the idea of variety and having relationships with patients over time. There's some medical specialties where you only interact with people once, and perhaps that may be it. So I like this kind of idea of looking after long-term conditions, multi-system disease. At the time, in the early 2000s, there were a lot of new therapeutics coming out in rheumatology, so it was quite an exciting area. And it's very multidisciplinary, both in terms of doctors working with nurses, physiotherapists, other allied health professionals, but also working across specialty and across conditions. So just lots of elements of that appealed to me.
Right. So talk to us a bit about your groups. The first, I believe, primary care osteoporosis research group in the United Kingdom. What kind of work you do there in this condition, other musculoskeletal disorders, and how your approach has evolved over the years.
Okay, so we do health services research, which is really practical stuff about identifying problems with care, understanding what the reasons for those problems are, and thinking about developing interventions and practical things to improve healthcare. So it's really practical and applied. Um, and when I joined Keele, there was a large osteoarthritis research group there, which is where I sort of started my research. And then I had the privilege to be able to learn from that and learn from and bring with me a lot of the people I'd worked with in osteoarthritis to set up an osteoporosis or sort of bone research group. And in applied health research, again, it's very multidisciplinary, but this time the disciplines I'm talking about are psychology, sociology, even business studies, education, bringing together lots of different experiences to really understand what's going on.
Right, right. Yeah, I mean, some of the things you said, and in answering my prior question, it always struck me. I was fascinated by your area. Things like the skin manifestations of the arthritis, or the arthritic manifestations of diseases like psoriasis, and you're right. The number of changes in rheumatology in my professional lifetime have been quite astonishing. So you're internationally recognized for your expertise in shared decision making, and you gained a prestigious NIHR Clinician Scientist Award a few years back. How has this concept transformed patient care in rheumatology and osteoporosis management, and its impact on outcomes, shared decision making?
Oh, that's a great question. I'm not sure it has transformed care yet, but I'm working on it, and our group are working on it. But I suppose where we've landed with shared decision making is that it's got two advantages. So one is that it improves person-centered care and being more making sure that the patient is really involved in the conversation and that any plans that you make fit with their lives. But the second part of it is that there's an advantage for healthcare professional goals as well, because if you use the principles of shared decision, it's more likely that the patient's going to be concordant, or you might call, say, adherent with the management plan that you decide together. And I guess that's probably where I started at my this clinician scientist. It was looking at the problem of the uptake of drugs being very low in osteoporosis and just trying to understand why that was, and using a health psychology lens to think about how patient and healthcare professional beliefs play into all of this. So that shared decision making is a tool to kind of unlock that. And I hope we're on a sort of journey to improve medicine uptake, but also I think to improve the narrative of osteoporosis care, because it's very biomedical at the moment, and this and also been a bit slow to update to recognise the importance of person-centred care. So some of the writing about osteoporosis is still quite what you might call paternalistic or parentalistic, in the patient's not doing what we tell them. So the transformation we're trying to make is to make the narrative more person-centered, and by doing that, we're likely to increase medicine uptake, if that makes sense.
Well, is there a parallel, like with hypertension? Osteoporosis, unless you've had a fracture, it's asymptomatic. So, is there a parallel? I mean, I remember
Absolutely.
my late dad. He was saying, I don't have any symptoms. Why should I take these drugs?
Yeah, there is, and there's a you could say there's a parallel with high cholesterol and
Mhm.
in
Sure.
silent condition. But I think
Mhm.
the difference is that most people have got some sense of what it's like to have a heart attack or a stroke, which is the thing that you're trying to prevent. Whereas in osteoporosis, the thing we're trying to prevent is a hip fracture or a spinal fracture, and there isn't a common understanding of what that means. We do a lot of community events where we do sort of myth busting exercises and get people to understand what people already know about bone health. And the two things that really shock people are what the outcomes of hip and spine fractures are. So the majority of people think you just recover from a hip fracture. People don't realize that a third of people that have a hip fracture can't go home afterwards. And the other thing that people don't realize is that spinal compression fractures cause that change in shape in your spine, which makes you shorter and more curved over, which is just normalized as part of aging. I mean, we've got that road sign in the UK where people are stooped over to warn of elderly people, and that image is just associated as, well, that's something that happens when you get older, but actually people don't realize that that's a product of spinal fractures.
Yeah, many years ago, Zoe, I was living and working in Los Angeles at Cedar Sinai Medical Center, sort of in the heart of Hollywood.
Wow.
And I had some very interesting patients and some very interesting experiences. One involved a husband and wife team who were on a show called LA Law.
Oh, yeah.
It was an actor named Michael Tucker and his wife Jill Eikenberry. Jill was one of the stars of the program. And I'd been introduced to Jill, and she was a very slight lady, very petite, very, very fit, very slim. And she'd had breast cancer. And uh, we got chatting, and I asked her about screening for osteoporosis. And she said, "No, I've never been screened. No one's ever talked to me." And I said it might be a good idea. So she got screened, and she had profound osteoporosis. And her relationship with her husband was fantastic, and they were always taking the mickey out of each other. And he was saying, "Oh, here we go. Another bloody female related disease, something men don't have to worry about." And I looked at him. He was a very short guy, and I said, "Michael, men get it also." And I said, "Get screened." He said, "Oh, I won't have it. I've got no symptoms." He was profoundly osteoporotic. And they ended up, the reason I can mention their names is because they ended up doing a public awareness campaign on getting screened for osteoporosis, Know Your T Score. And it sort of had a golf theme. And the reason I mention this, Zoe, the impact was fantastic. There was huge uptick in screening, and I've seen that. I saw that in America a lot. Worked on a number of programs with high-profile celebrities who were passionate about a health issue, and it changed clinical practice. Have we ever done anything like that in Britain? And if not, why not?
That's a great question. There's a few parts to the answer. So I'm going to start off by saying if we were going to do screening, it wouldn't be with bone density scans first line.
Mhm.
And the
Well, this
reason,
was a number of years ago.
yeah, the reason is that the bone density scan is not the be all and end all, and it's just part of the picture. And now we take a risk assessment based approach. Now, in terms of should we be doing screening, it's a fantastic question. So, there was a big trial here in the UK called Scoop a few years ago, which uh, did just that. So it was a population screening in older women and sent them all questionnaires in the post to do that fracture risk assessment. And then those that needed it were sent a bone density scan. There was about 13,000 women in that trial, I think. And that um, overall, the patients were randomized to either be screened or not be screened. And overall, the results showed that the primary outcome, the main outcome, which was meant to be reduction of all fractures, wasn't different between the groups. But in the screening group, there were less hip fractures, and overall, the screening was seen as cost effective. Now, the National Screening Committee in the UK, who review all the evidence for these kind of things, felt that that wasn't sufficient evidence to recommend a screening programme. Looking at other screening trials that have happened in other countries and things as well. And I think what we're looking at Keele is trying to build on that research and go then say, well, okay, what's the next step? So for us, it's about including men as well, and other underserved groups, because in general, the people that participated in Scoop were probably of better socioeconomic status and predominantly white. So we really want to focus on people that weren't included in that. We want to take a targeted approach instead of a population-based approach. So that means that we'll be focusing on people who've got risk factors rather than just a blanket for everybody. And we're just trying to get funding for that at the moment. So I think there's a signal there that it is something we should be doing, but how we do it, and the other aspect to it is we want to take a bit more of an automated approach rather than relying on paper questionnaires and things. So I think how we do it and the population that we target is key to getting that evidence that we need to be able to roll this out.
Sure, sure. Well, when you do, I don't think there'll be a shortage of high-profile spokespeople who can
Yeah.
raise the profile of the condition. So that wraps up part one of our series. Thanks for listening. Be sure to join us for part two, where we continue the conversation and uncover even more valuable insights.